Hey, welcome back to Not So Complicated, and it's our session 2 of renal pathology. We have completed our general principles, then respiratory pathology, cardiovascular pathology, gastrointestinal pathology, and also hematology and oncology. We have completed our first session on our renal pathology, and this is our second session, and most probably we'll complete the portion today. And if we couldn't, or if we can't complete today, we will then continue in our next session, right? So if you are new here, get connected with us. So without further delay, we are resuming our session like this. So basically, kidney stones is our first topic. So what are kidney stones? Kidney stones are also called renal calculi. There are stones present in our urinary system, right? So they can be of different constituents like calcium, ammonium, magnesium, phosphate, uric acid, and also cysteine. We'll talk about each of them and in our upcoming classes, in our upcoming time, right? So basically, kidney stones can lead to severe complications such as hydronephrosis. Hydronephrosis, we'll talk about it, and then pyelonephritis and also acute kidney injury. The obstructed stone presents with unilateral flank tenderness. Flank tenderness is the side of your abdomen, two sides of your abdomen, and also colicky pain, which is sharp pain radiating to the groin, that is inner thigh region, and also hematuria is present, that is red blood cell casts are present. That we can treat and prevent by encouraging fluid intake. The radiolucent stones are also there. So radiolucent is that they are not seen in X-ray findings actually. So they are called radiolucent. So not seen. So there is a mnemonics, that is I can't see you. So C means cysteine stones and U means uric acid stones. So uric acid stones and cysteine stones are radiolucent and can be seen in X-ray. So we have to do what? We have to do CT scanning for them, right? So let's go one by one. Calcium is calcium oxalate. Calcium has two types. One is calcium oxalate and also another is calcium phosphate stones. So calcium oxalate stones precipitates with hypocitraturia, and the extra findings is radiopaque, hyperdense, and this is very specific here, which is shaped like envelope or dumbbell. Let's see the figure here. You can see here, this is shaped like dumbbell right here, or like envelope, right? Just like envelope, it looks like envelope. So that is how it looks. And calcium stones are actually most common in 80% cases, and then calcium oxalate more common in calcium phosphate stones. And so calcium oxalate are more common than calcium phosphate stones. So they can result from ethylene glycol, that is antifreeze ingestion, and also vitamin C overuse, hypocitraturia, usually associated with decreased urine pH. This is the one thing that you have to remember, that is decreased urine pH precipitates calcium oxalate stones, but increased pH is there in calcium phosphate stones. So you have to remember that, and you can treat by thiazide, citrate, and low sodium diet, right? So calcium phosphate stones are also radiopaque in X-ray findings, hyperdense in CT findings, and wedge-shaped prism are present. Wedge-shaped prism are present in these cases, and the treatment is low sodium diet and also thiazides, right? So another stone type is struvite. S for struvite, S for sarcophagus. This is a very high mnemonic, sarcophagus, and it looks like coffin lid. It looks like coffin lid in urine crystals, and it is also radiopaque. It also precipitates in increased pH, and hyperdense findings are in CT. They account for 15% of stones and caused by infection with urease positive bugs. This is very common because urease positive bugs usually form ammonia, right? So ammonium magnesium sulfate can be easily precipitated in that cases. So the bugs like that are Proteus mirabilis, Staphylococcus saprophyticus, Klebsiella, that hydrolyze urea to ammonia. The more the ammonia, the more the ammonium crystals like that. So struvite cases are also occurring in here, right? So urine alkalinization is there. It commonly forms Staghorn calculi. This is what you have to remember. This is very high yield. You can note it down right here. Staghorn calculi. You can look. This is Staghorn, right? Staghorn calculi are present in this case. So the treatment is eradication of underlying infection and surgical removal of stone. eradication of underlying infection, and surgical removal of a stone, because Staghorn calculi is usually very obstructive in pelvis region, not pelvis kind of pelvis, but there is a pelvis region of ureter, right? That is the outlet. That is where Staghorn calculi obstructs. Also uric acid, they precipitate in decreased pH. Cysteine is also precipitated in decreased pH. So what is common here? Calcium oxalate in decreased pH, but calcium phosphate in increased pH. So phosphate and ammonium magnesium phosphate. So wherever there is phosphate, it's increased pH, and uric acid and cysteine, they are decreased pH. What is more common here? They both are radio-opaque, right? They both are radiolucent. They are faintly radio-opaque, but we can say they are radiolucent. And it is visible in CD, moderately radio-dense in CD. Cysteine is, and also the crystals are rhomboid shaped in the case of uric acid, or rosettes. They look like rosettes, rhomboid shape. This is rhomboid shape, right? So uric acid crystals are rhomboid in shape. Also, let's talk about cysteine acid. Cysteine, yes, cysteine crystals are like this here, hexagonal shape, right? Hexagonal shaped. So basically, the uric acid crystals, they are present in about 5% of all stones, and risk factors, arid climatics, and also acidic pH. And also they have strong association with hyperuricemia, that is in gout. A patient with gout often presents with urinary stone, that is renal calculi, and often seen in diseases with high cell turnover, as in leukemia. So since uric acid is the end product of protein metabolism, right? So that is why in high cell turnover cases, the uric acid amount increases, and the more an increase in uric acid, that will cause the more chance of precipitation as a stone, right? So the treatment is alkalinization of urine and also allopurinol. So cysteine, there are hereditary, that is autosomal recessive condition in which cysteine reabsorbing PCT transporter loses function, causing cystinuria. This is what it happens. This is autosomal recessive dysfunction. Okay, cysteine. This is autosomal recessive dysfunction. Transporter defect also results in poor reabsorption of ornithine, lysine, and arginine. So what happens? Not only cysteine, there is CoLA. CoLA happens in this hereditary autosomal recessive condition where there is cysteine reabsorbing PCT transporter losing its function. So C for cystinuria, cysteine reabsorption is impaired, ornithine, and here lysine, and here arginine. So this all reabsorption are impaired. Cysteine is poorly soluble, thus stones form in urine because cysteine is poorly soluble. And usually it begins in childhood, can form Staghorn calculi. Sodium cyanide nitroprusside test is positive. Okay. SCN test is positive. If it is abbreviated as SCN, you do not have to be confused. It is sodium cyanide nitroprusside test, and 16, that is stones have 6 sides, right? Cysteine, 16, so hexagonal shape. Treatment is low sodium diet, alkalinization of urine, sledding agents like thiopronin and penicillamine if refractory. So that is how we finish our stones right here. Let's talk about hydronephrosis. So what is hydronephrosis actually? So these stones are causing obstruction in the renal outflow, right? So the urine is not getting out of the kidney because of obstruction. That will cause distensional dilation of renal pelvis or calyces. You can see here, this is the dilatation here, right? Renal pelvis or calyces are dilated because of the outflow obstruction, mostly caused by urinary tract obstruction, as I have talked earlier, and then urinary tract stones, severe benign prostatic hyperplasia, or congenital obstructions, locally advanced cervical cancer, injury to ureter. Anything that causes obstruction in the urinary tract flow, that causes hydronephrosis. Other causes include retroperitoneal fibrosis, vesicoureteral reflex. That means that the urine is not coming down, but it is going up to the kidneys, right? So that is what vesicoureteral reflex. And also dilation occurs proximal to the site of pathology. Obviously, that is very common, right? So if there, this is a duct and here is the obstruction, obviously the outflow cannot go like that. So dilation occurs proximal to the obstruction like this. This is very simple logic, right? So serum creatinine becomes elevated if obstruction is bilateral or if patient has an obstructed solitary kidney. It leads to compression and possible atrophy of renal cortex and medulla. That is what it happens in every obstructive cases. The normal cortex is atrophied because of compression, right? So in also hydrocephalus cases, that will cause the compression of possible, like that will cause compression of cortex, neocortex, right? Gray matter, white matter, and that causes eventually atrophy too. And also herniation, tonsillar herniation can be done in that cases in hydrocephalus. So everything that is compressed will go atrophy. That is simple logic. So let's talk about urinary incontinence. Urinary incontinence is that mixed incontinence has features of both stress and urgency incontinence. Incontinence typically means that we are unable to control our urinary outflow. So we are peeing unconsciously. So there is different types. So stress incontinence, urgency incontinence, and then overflow incontinence. Let's talk about each of them. So mechanism of stress incontinence is that there is outlet incompetence, urethral hypermobility or intrinsic sphincter deficiency is there, that will lead to leak with that will lead to leak with increased intra-abdominal pressure. Example is sneezing or lifting, like when we sneeze and lift. Plus bladder stress test, directly observed leakage from urethra upon coughing or Valsalva maneuver. That is when it occurs. So there is stress, there is outlet incompetence, like here should be sphincter. Sorry. So this is the sphincter right here actually. This is the sphincter right here. And then there is hypermobility of this sphincter, right? So sphincter deficiency can also occur, and that is very, very incompetent. And whenever there is stress like that, as in coughing or sneezing, then the urine droplets dribble out of urethra. That is what it is called stress incontinence. There it is associated with obesity, pregnancy, vaginal delivery, and prostate surgery. The treatment are pelvic floor muscle strengthening, that is Kegel exercises we have to do, and weight loss and pessaries. That are the treatment, right? So in urgency incontinence, what actually happens is there is detrusor over activity, that is leak with urge to void immediately. It doesn't have to be that the bladder is full. It can occur in certain UTI cases, right? So urgency can occur due to hyperactivity of detrusor muscles. So the associations is bladder irritation from UTI, as I have talked. UDI has most common symptoms as urgency if it is lower UDI, and also stones, tumors, and pelvic radiation can do the same thing. And the treatment is pelvic floor physical therapy, bladder training, that is timed voiding. This is what it is: timed voiding, distraction, or relaxation techniques. So we have to remember like that. And then antimuscarinics can be used, example oxybutynin for overactive bladder, and also mirabegron or pibregron we can use like that. And there is overflow incontinence. This can happen in every emergency. Suppose you are in a class in 1 hour, and since the beginning of the class your bladder is full. So what happens? There is incomplete emptying of detrusor underactivity or outlet obstruction. It doesn't have to be. If you can voluntarily not pee in foreseeable cases, right? So in that cases also it can occur overflow incontinence. That will lead to leak with overfilling, and also post-void residual uncatheterization or ultrasound can cause this too. So urinary retention, polyuria as in diabetes, bladder outlet obstruction, spinal cord injury, this can happen in these underlying diseases, but they can also happen in voluntary control. So catheterization, relieve obstruction are the treatment. Alpha blockers for benign prostatic hyperplasia can be done. So this is how we complete our urinary incontinence. Let's talk about acute cystitis. This is inflammation of gallbladder. Acute cystitis is inflammation of gallbladder. It presents as suprapubic pain, dysuria, which is difficulty in urinating, frequency, and urgency. These are classical symptoms of acute cystitis, and systemic signs like high fever cells are usually absent. So in acute cystitis, high fever cells are usually absent. So pain, suprapubic, that even suprapubic pain. Suprapubic, you might know where is the pubis bone, right? You must know. So there is this suprapubic pain in this region, and also dysuria is difficulty in urinating, and urgency and frequency. Urgency is you have to pee right now, that is urgency, and frequency is you have to pee repeatedly, that is frequency. They are both associated. And also risk factors include female sex, because there is short urethra and sexual intercourse, indwelling catheter, diabetes mellitus, and impaired bladder emptying. But all of this can cause acute cystitis. The causes are normal flora that laws in other than the site of gut that can cause infections like this, right? So E. coli is the most common. Staphylococcus saprophyticus, seen in sexually active young women. E. coli is still more common in this group, but it is seen in sexually active young men, right? Women. And also Klebsiella, Proteus mirabilis, that urine has ammonia scent, and Enterococcus species. All of these organisms can cause acute cystitis. So the lab finding is that the leukocyte stearase test is positive, nitrites positive, indicates presence of Enterobacteriaceae, and sterile pyuria. Pyuria with negative urine cultures. Pyuria is that in urine there is pus. The pus is present in urine, but there are no urine cultures positive in pus. So what actually it is? Sterile pyuria, right? And also cursus urethritis by Neisseria gonorrhea or Chlamydia trachomatis. So in urethritis caused by Neisseria gonorrhea or Chlamydia trachomatis, there is sterile pyuria present. So you have to remember that too. The treatment is antibiotics, that is TMP, SMX, and also nitrofurantoin are used, right? TMP is trimethoprim. And then let's talk about pyelonephritis. So there are two types of pyelonephritis, acute pyelonephritis and chronic pyelonephritis, obviously, and they are of two different duration. So the duration specifies which is this, right? So neutrophils infiltrate renal interstitium in this case, neutrophils. You can see these all blue dots, all of them are neutrophil infiltrates. These are tubules here, right? So if you don't know how to read histology slides, I have made a complete guide of 35 minutes, step-by-step guide, and you can watch that, right? So it affects cortex with relative sparing of glomeruli and vessels. It presents with fevers, flank pain, that is costovertebral angle tenderness, and also nausea, vomiting, chills. The causes include ascending UTI, that is the UTI is going up from the urethra to the kidney. E. coli is the most common. Hematogenous spread to the kidney can also occur, and presence with WBCs in urine with or without WBC casts. CT would show striated parenchymal enhancement. There is striated parenchymal enhancement. And also risk factors include indwelling urinary catheter, urinary tract obstruction, vesicoureteral reflux, and also diabetes mellitus. Pregnancy, that is progesterone mediated decrease in ureter tone, compression by gravity uterus. These all are risk factors. The complications include chronic pyelonephritis. Obviously, every acute inflammation has a complication of chronic inflammation, and renal papillary necrosis can occur. So papillary necrosis is that there are different papillae present, right, in kidneys. It can go necrot. It can be necrosed, and perinephric abscess can cause with possible posterior spread to adjacent psoas muscle, and also urosepsis can occur. So the treatment is antibiotics, obviously, because all of these are causing by bacteria or any pathogen. So chronic Pyelonephritis is a result of recurrent or inadequately treated episodes of acute pyelonephritis. Obviously, there is no other reason for that, and it typically requires predisposition to infections such as vesico-ureteral reflux or chronically obstructing kidney stones. So, the coarse asymmetric corticomedullary scarring and blunted calyces are seen. The calyces are blunted in this case. You have to remember this. Corticomedullary scarring and blunted calyces. The tubules can contain eosinophilic casts resembling thyroid tissue. So thyroidization of kidney occurs, you can see. So how does this happen? So actually this is a tubule, let's say, and here are cells, right? Here are cells and there is a lumen in between. And these cells now get destructed and cast the debris. And the debris will fill this wall, causing thyroidization of the kidney. So that is the specific finding in chronic pyelonephritis that you cannot at any cost forget: thyroidization of kidney. So let's talk about acute kidney injury. There are different etiology and different types of acute kidney injury. One of that is pre-renal azotemia, intrinsic renal failure, and post-renal azotemia. There are very specific differences for three of these, and you have to remember each of them with equal importance. And then we'll talk about acute interstitial nephritis. Okay, so the etiology of pre-renal azotemia, that is before kidney, is hypovolemia, that is decreased output. Azotemia is actually increased in blood urea nitrogen. Blood urea nitrogen is increased BUN level, right? So it can occur with three different causes: pre-renal, renal, and post-renal. You have to remember this all. So pre-renal is that nothing is affecting in kidney. It is before kidney cases, that is hypovolemia, as in decreased cardiac output or decreased effective circulating volume. So there is decreased glomerular filtration rate. Renal blood flow is decreased, obviously, because there is decreased circulating volume, and that will lead to decreased glomerular filtration rate and thus increased reabsorption of sodium and water and urea. That is why blood urea nitrogen is increased. And also urine osmolality, milliosmol per kg, that is greater than 500. Urine sodium is less than 20 because there is extensive reabsorption of sodium, and fractional excretion of sodium is less than 1%. Serum BUN by creatinine ratio is greater than 20. This ratio is what we defines the different types of acute kidney injury in clinical picture. Okay, let's talk about intrinsic renal failure. Everything that is happening in kidney or renal system or urological system. So tubules and interstitium, let's talk about that. There is acute tubular necrosis by ischemia or nephrotoxins like nephrotoxic drugs, right? We'll talk about this. Or there is acute interstitial nephritis in tubules and interstitium. So in tubules, there is acute tubular necrosis. In interstitium, there is acute interstitial nephritis. And in glomerulus, there is acute glomerulonephritis. Or in the vascular edge of renal arteries, there is vasculitis, hypertensive emergency or TTP, hemolytic uremia syndrome that can happen, right? So in acute tubular necrosis, there are patchy necrosis, which will lead or cast the debris, obstructing tubules and fluid backflow, causing decreased GFR. What actually happens is, for example, this is tubule. Now these walls have cells, and these walls of cells get infected, now destructed. They release the cast, and that will cause the cast obstruction. So there is no flow of GFR here. That will lead to reversed flow, that is fluid backflow, and also lead to decreased in GFR. So there is a urine osmolality of less than 350, urine sodium in milliequivalent polyuria is greater than 40, and fractional excretion of sodium is slightly larger than pre-renal, that is greater than 2%, and serum BUN by creatinine ratio is less than 15. And in post-renal azotemia, it is everything except kidney. It can occur stones in urinary tract, ureter, right? Or in urinary bladder, urethra, anything. And it can be due to benign prostatic hyperplasia, neoplasia, like prostate cancer can also do that, and congenital anomalies. And also here, urothelial carcinoma can also do that. Congenital anomalies can also cause postrenal azotemia. It is outflow obstruction, that is bilateral. There should be bilateral. Then in the cases like Staghorn calculi, it can cause outflow obstruction, that is bilateral. So urine osmolality varies, urine sodium varies, fractional excretion of sodium also varies, and serum BUN, Becquerel ratio, also varies. Let's talk about acute interstitial nephritis, what it is actually. So it is also called tubulointerstitial nephritis, acute interstitial renal inflammation. It is also called like that. There is pyuria and azotemia occurring after administration of drug that acts as haptens, inducing hypersensitivity, like diuretics, NSAIDs, penicillin derivatives, proton pump inhibitors, rifampin, and quinolones and sulfonamides. This is the actual reason. So there is acute interstitial renal inflammation caused by administration of nephrotoxic drugs that act as haptens, inducing hypersensitivity reactions, right? The drugs examples are rifampin, quinolones, sulfonamides, as we have talked. And the classic symptoms are pyuria and also azotemia. In pyuria, there is pustules. The pustules are classically eosinophils in this case. It is less commonly maybe secondary to other processes as systemic infections like mycoplasma or systemic inflammatory disorders like Sjogren's syndrome, SLE, and sarcoidosis. SLE is systemic lupus erythematosus, you all know that. And it is associated with fever, rashes, pyuria, hematuria, that is red blood cell cast, and also costovertebral angle tenderness. But can be, this is also called flank pain, right? Upper flank pain, but can be asymptomatic. Remember the causes of inflammation to your drains. D for diuretics, R for rifampin, diuretics, rifampin, A for antibiotics, mainly penicillins and cephalosporins, and then P for, there is I for inhibitors, proton pump inhibitors, N for NSAIDs, and S for sulfa drugs, so drains. D is diuretics, R is rifampicin, A is antibiotics like penicillins and cephalosporins, and I is proton pump inhibitors, N is NSAIDs, and S is sulfa drugs. So drains, you have to remember these causes. So let's talk about acute tubular necrosis. So now we'll talk about acute tubular necrosis, renal papillary necrosis, right? Say these are the reasons, these are the topics we will cover, and then here we finish. Let's see how much can I do in single session. So acute tubular necrosis, let's talk about that. Acute tubular necrosis, it is the most common cause of intrinsic acute kidney injury in hospitalized patients. You have to remember this. A patient is hospitalized and there is intrinsic acute kidney injury. It is the most common cause. Spontaneously resolves in many cases, can be fatal, especially during initial oliguric phase. There are phases for acute tubular necrosis. There is increase in fractional excretion of sodium. The key findings are granular cast, often muddy brown in appearance. This is how it looks like. Muddy brown. You have to remember, muddy brown in appearance, that is in acute tubular necrosis. The casts are muddy brown in color. So 3 stages, that is inciting event, maintenance phase, which is oliguric phase. It lasts for 1 to 3 weeks. There is risk of hyperkalemia, metabolic acidosis, and uremia. The third phase is recovery phase, which is polyuric. BUN and serum creatinine fall in this case. Risk of hypokalemia is there. And also because it is polyuric case, right? So there is risk of hypokalemia, and renal wasting of other electrolytes and minerals can occur. It can be caused by ischemic or nephrotoxic injuries. 2 reasons are there: ischemic and nephrotoxic. Ischemic is secondary to decreased renal blood flow, as in pre-renal azotemia. Everything that causes pre-renal azotemia causes this. So it results in death of tubular cells that may lodge into the tubular lumen, as we have talked, the casts obstructing the tubular cells in this figure right here. This figure, casts obstructing the tubules, right? So This is how it looks, the cast. It is not completely obstructing this time, but it is at least obstructing. And then PT and thick ascending limb are highly susceptible to injury. So the nephrotoxic drugs secondary to injury resulting from toxic substances like aminoglycosides, radiocontrast agents, lead, cisplatin, ethylene glycol, uric acid in tumor lysis syndrome, myoglobinuria like rhabdomyolysis, and also hemoglobinuria. PTs are particularly susceptible for injury, that is proximal tubules are particularly susceptible. So tumor lysis syndrome we have talked about in general principles, you can look at that, right? So I am not repeating it, it's your homework. And also diffuse cortical necrosis is here. Acute generalized cortical infarction of both kidneys can occur. It is likely due to combination of vasospasm and DIC, which is disseminated intravascular coagulopathy. So it is associated with obstructive catastrophes like placental abruption, and also in septic shock it can occur. So let's talk about renal papillary necrosis, which was one of the major complications of what? Hydronephrosis, right? Let's talk about it. It is slowing off of necrotic renal papillae that causes gross hematuria. Gross hematuria. You don't even have to look at the microscope to see the red blood cell cast. Your urine is entirely red. So it may be triggered by recent infection or immune stimulus, right? So it is associated with sickle cell disease, a trait, acute pyelonephritis, analgesics like NSAIDs, and diabetes mellitus. So basically, sad papa with papillary necrosis, you can remember like that. Sad papa with papillary necrosis. S for sickle cell disease, A for acute pyelonephritis, A for analgesics, and D for diabetes mellitus, and papa because papillary necrosis. So let's talk about consequences of renal failure. What actually happens if there is entire renal failure? There is decline in renal filtration that can lead to excess retained nitrogenous waste products and electrolyte disturbances, right? So the consequences we can remember by these mnemonics: mad hunger. One of them, M for metabolic acidosis occurs. MA is metabolic acidosis. D is dyslipidemia occurs, especially increased TG. H is high potassium. Metabolic acidosis occurs due to the decrease in H plus secretion, right? Dyslipidemia occurs because there is increase in protein secretion like albumin. Proteinuria is there, and to compensate that, the body will try to form ApoB100 protein, and that is gamma globin, and also gamma globinuria occurs, right? So that is lipoprotein that will lead to increase in triglycerides. That is why dyslipidemia is there. High potassium because potassium excretion is abrupted. Uremia because urea is retained. Urea retention is there. Sodium water retention is there. That causes heart failure, pulmonary edema, hypertension in the long run. There is growth retardation and developmental delay. There is erythropoietin deficiency, which lead to anemia, and there is renal osteodystrophy. So mad hunger is a very nice mnemonic to remember what actually happens in renal failure. So two forms of renal failure are there, acute and chronic. In acute cases like acute tubular necrosis can cause the renal failure, and in chronic, hypertension, diabetes mellitus, or congenital anomalies can cause the renal failure. The incremental reductions in GFR define the stages of chronic kidney disease, right? So there are the stages actually. So stages are grade 1, 2, 3A, 3B, 4, and 5. That depends on glomerular filtration rate. So let's talk about what's there. So the normal phosphate levels are maintained during early stages of CKD due to increased levels of fibroblast growth factor. FGF3, FGF23 will maintain normal phosphate levels, which promotes renal excretion of phosphate. So FGF23 fights for phosphate, right? FGF3 increases the phosphate excretion, so the normal phosphate levels are maintained during early stages, right? So uremia syndrome resulting from high serum urea, it can present with pericarditis, encephalopathy seen with asterexis, that is flapping tremor, and also anorexia, nausea, pronounce as European, you can, okay, that is nice. European, uremia, there is pericarditis, E is encephalopathy, with asterisk, A is anorexia also, and N is nausea. That can occur in uremia. These are the classical symptoms of uremia. So European is the mnemonics, okay. Let's talk about renal osteodystrophy. What actually happens here is hypocalcemia, hyperphosphatemia, and failure of vitamin D hydroxylation associated with chronic kidney disease. Because vitamin D, in the synthesis of vitamin D, there are two hormones required. One of them is in liver, another of them is in kidney. And since there is kidney injury, the vitamin D hydroxylation cannot occur, right? So that causes failure of vitamin D hydroxylation, and hypocalcemia and hyperphosphatemia occurs. So hyperphosphatemia, because there is decrease in phosphate excretion, and that phosphate level increases in serum level, that will competitively inhibit the excretion. So there is reabsorption of calcium that causes hypocalcemia, right? So basically, this all is causing secondary hyperparathyroidism and also tertiary hyperparathyroidism if secondary poorly managed. High serum phosphate can bind with calcium, causing tissue deposits, so decrease in serum calcium. This is the reason. High serum phosphate can bind with calcium in tissue deposits, causing decrease in serum calcium. This is one of the reason. Another reason is that increased level of phosphate competitively inhibits calcium reabsorption from the kidney. So decreased intestinal calcium absorption is also there because there is vitamin D deficiency. That will also cause hypocalcemia and causes subperiosteal thinning of bones, right? That is it. Renal cyst disorders. Let's talk about autosomal dominant, which is renal cyst disorders. There are polycystic kidney disease, right? There are two types, type 1 and type 2. So type 1 is autosomal dominant polycystic kidney disease, and type 2 is autosomal recessive polycystic kidney disease, PKD. In autosomal dominant polycystic kidney disease, there are numerous cysts in cortex and medulla, and like this, numerous cysts here, right? And then they cause bilateral enlarged kidneys, ultimately destroy kidney parenchyma. They present with combination of flank pain and hematuria, hypertension, urinary infection, progressive renal failure in 50% of the individuals. So mutation in gene encoding polycystin protein, PKD1. This is the classic predisposing gene genetic disorder. So 85% of cases in chromosome 16, and PKD2 15% of chromosome in 15% of cases in chromosome 4. The complications include chronic kidney disease, hypertension caused by increased renin production, and associated with berry aneurysm. Berry aneurysm is the aneurysm of the anastomosis in brain, right? So that there is the reason for benign aneurysm. There are different reasons with different propensities, and also mitral prolapse can occur. Benign hepatic cysts and diverticulosis also are associated in this case. And the treatment is, if hypertension or proteinuria develops, we have to treat with ACE inhibitors or ARBs, that is angiotensin receptor blockers. So autosomal recessive polycystic kidney disease, there is mutation in PKHD1 encoding fibrocystine. Here there was mutation in polycystin protein. Here there is mutation in fibrocystin. There is cystic dilatation of collecting ducts, as you can see here. Cystic dilatation of collecting ducts are there, often present in infancy and may be seen on prenatal ultrasound. It is associated with congenital hepatic fibrosis and then also significant oliguric renal failure in utero can lead to Porter sequence. This is very specific finding for autosomal recessive polycystic kidney disease. We have to remember that. So this is a disease of adults, dominant, and this is a disease of infants. The concerns beyond neonatal period include systemic hypertension, progressive renal insufficiency, portal hypertension from congenital hepatic fibrosis. Okay, let's talk about autosomal dominant tubulointerstitial kidney disease, simple versus complex renal cyst. So Autosomal dominant tubulointerstitial kidney disease, they are also called medullary cystic kidney disease. It causes tubulointerstitial fibrosis and progressive renal insufficiency with inability to concentrate urine. There is inability to concentrate urine. Okay, that is the main cause, main effect. And medullary cysts usually not visualized, smaller kidneys on ultrasound, poor prognosis is there. So simple cysts are filled with ultrafiltrate, that is anechoic, or on ultrasound. Anechoic is there is no specific finding, and also there is no sound heard in ultrasound. And then very common and account for majority of all renal masses, found incidentally and typically asymptomatic. And complex cysts, including those that are septated, enhanced, or have solid components and imaging, require follow-up or removal due to possibility of renal cell carcinoma. Okay, let's talk about renovascular disease, right? This became a very long session, right? Let's talk about renovascular disease and renal cell carcinoma, renal oncocytoma, nephroblastoma. Here we finish. So tumors, only tumors are left. Okay, renovascular disease. So unilateral or bilateral renal artery stenosis is there, that will lead to decrease in renal perfusion. So that will lead to increase in renin, right? And increase in renin is increase in angiotensin, causing hypertension. That is where it occurs. Most common cause of secondary hypertension in adults is renal artery stenosis. Secondary cause of hypertension, secondary hypertension in adults is renal artery stenosis. Main causes are atherosclerotic plaques can be there, proximal 1/3 of renal artery, usually in older males and smokers, or fibromuscular dysplasia can be there, distal 2/3 of renal artery, or segmental branches, usually young and middle-aged females. For unilateral renal artery stenosis, affected kidney can atrophy asymmetric kidney size thus. So in unilateral cases, the kidney sizes are asymmetric, and renal venous sampling will show increased renin in affected kidney, decreased renin in unaffected kidney. Right? So in bilateral RAS, renal artery stenosis, patients can have a sudden rise in creatinine after starting an ACE inhibitor, and also ARB, a renin inhibitor, due to their interference on RAS-mediated renal perfusion. Okay, they can present with severe or refractory hypertension, flash pulmonary edema, epigastric or flank fluid, and then patients with RAS may also have stenosis in other large vessels, right? So aldosterone, this is proximal 1/3 and distal 2/3, right? In proximal 1/3, atherosclerotic plaques and fibromuscular dysplasia in distal 2/3. So ischemia, renin release, angiotensin is converted to angiotensin 1, and then it is converted to angiotensin 2, which will lead to sodium retention and also directly act on the adrenal gland to release aldosterone, and also vasoconstriction, hypertension. These all the main effect here is hypertension. So let's do that for today, because we have to read these tumors in a very fresh mind. I will do a very short session for these tumors tomorrow. Thank you for staying with me. If you are still here, and subscribe and share, for we have to cross this USMLE Step 1, getting 260 plus and the residency of our dream, right? So thank you.